In this video and the next, I'll be introducing some important concepts and terminologies that pertain to spinal manipulations. Now, in the vast majority of clinics, when somebody throws around the term manipulation or they say, I'm going to manipulate this patient, they're referring to something very specific, and it is very different than a mobilization. Now, in theory, mobilizations and manipulations are similar, but in reality, the way that they are executed is very different. So one thing we want to understand here in this video is the difference between a mobilization and a manipulation, and there are several differences that are important to understand. So when somebody uses the term mobilization, what they're referring to generally are Maitland mobilizations. So Maitland was a guy who decided that you can grade mobilizations on a scale of 1 to 4. Okay, where 1 is the least intense and 4 is the most intense. And the commonality between all of these mobilization grades from 1 to 4 is that they're done at a low velocity. So when somebody says, I'm going to mobilize this tissue, they're doing it at a low velocity. Okay? Now the exact amplitude and the proximity to end range of the mobilization depends on which grade you're using. Okay? But the constant is that they're all done at a low velocity. In just a second here, I am going to go into these grades in a little bit of detail, but if you want a lot more detail, especially how these mobilizations are applied, go watch this video by following the link in the description of this video, where I go into these grades in much more detail. Over here you see grade 1 mobilizations. These are small amplitude rhythmic oscillating mobilizations in the early range of movement. So here's the beginning range of movement, just barely sinking through the skin even. Very small range. Grade 2 mobilizations, these are large amplitude rhythmic oscillating mobilizations in the mid-range of movement. So sinking a little bit into the tissue and then going just up to tissue resistance. These are grade 2 mobilizations, and collectively grades 1 and 2 mobilizations are normally used for reducing pain. And you should never jump into grades 3 and 4 first. You should always assess the patient's response just to grade 1 and then 2 before diving deeper, which leads us to grade 3. These are large amplitude rhythmic oscillating mobilizations to the point of limitation in range of movement. So first find that first tissue resistance, then you're going all the way to end range. These are grade 3 mobilizations. And then grade 4, these are small amplitude rhythmic oscillating mobilizations at the end of available range of movement. So right at the end range. This is grade 4. And you can see here collectively grades 3 and 4 mobilizations. These are generally used to increase available range of motion. Now, one important thing here, in the literature, when somebody is talking about grades 1, 2, 3, or 4 mobilizations, what we just talked about, they are sometimes referred to as non-thrust manipulations. Now, even though the term manipulation is in the phrase, these are not what most people are talking about when they're saying manipulation. But understand in the literature, these mobilizations, or Maitland mobilizations, will sometimes be called non-thrust manipulation, emphasis on non. All right, we're finally getting down to the manipulations. Now the term manipulation refers to a special case of the Maitland mobilizations, which is grade 5. In other words, a manipulation is just a grade 5 mobilization. Now, as far as I know, nobody goes around saying how they're giving patients a grade 5 mobilization. They just say, well, I'm going to give the patient a manipulation. And I think this is a good thing because functionally speaking, a manipulation is delivered very differently than a mobilization. Their execution is very different. And I think it's important to make sure to differentiate these. So a mobilization really just involves those rhythmic oscillations, and they're more or less continuous. You might do them anywhere between 30 and 60 seconds. 30 to 60 seconds of continuous rhythmic oscillations. And they're low velocity. Whereas a manipulation is a quick thrust. It's not continuous. You don't continuously manipulate. You really just do a quick manipulation and then you pause and you reassess. Just one quick manipulation. So it's a quick thrust at or near end range at high velocity and at a low amplitude, meaning it doesn't cover a large distance. In other words, we can combine all these to say manipulations are high velocity, low amplitude thrusts, and that's where this acronym comes for, HVLAT. High velocity, low amplitude thrusts. If we look over here on the right, there's another quick definition of manipulations. They are small amplitude, quick thrusts at the end of the available range of motion or range of movement. And when they're executed correctly, they tend to both decrease pain and increase available range of motion. So backtracking here a little bit, when we talk about mobilizations, so the Maitland mobilizations between grades 1 and 4, usually you'll just refer to them as mobilizations, but they're also termed non-thrust manipulations. When we talk about what most people are referring to as manipulations, manipulations are also called thrust manipulations. They can be called grade 5 mobilizations, although most people don't refer to them as that. And in the chiropractic setting, they're termed adjustments. So sometimes you'll have patients come in and say, oh yeah, well, I had this adjustment done. Almost always, that's referring to a manipulation, a thrust manipulation. And also manipulations are done at a high velocity. Now, that begs the question, what defines high velocity and low velocity? Well, a mobilization, so like grades 1 through 4 here, these are done at a low velocity. And it's a velocity slow enough that the patient can react to and resist against the movement. So if we look back at that short clip here of the oscillatory mechanics of the mobilization, first of all, it's predictable, right? It occurs at roughly a constant rate. So again, if the patient wanted to resist or guard against the next or subsequent oscillation, they could definitely do that. And it's slow enough to where there's time to react and guard against that next oscillation. And then a manipulation, or HVLAT, high velocity, low amplitude thrust, is of course done at high velocity, that's the HV, and it's done at a velocity so fast that the patient cannot react in time to resist against the movement. Now, it is true the patient can be pre-guarded, and this is why you need to give appropriate education to try to get the patient to relax their muscles enough to actually get the thrust. But once the thrust is initiated, it's so fast that the patient cannot react in time to activate their guarding muscles to resist against the movement. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.